please ask, because a little bit light on questions tonight. I look at the list of questions a little bit before 7 o'clock, and I've looked at the list. I've got it here, and I've got 2 questions. I'll be honest with you. I've got 2 questions here, so I've got to string out 2 questions. But for goodness sake, if you've got a question and you've been holding it within you week in, week out, now is the time to get it out. Because I can tell you now, my friend, if you've got a question, you have got a very good chance of getting it answered. Did I tell Ella off on YouTube? Yes, I did tell Ella off on YouTube. Will it make any difference? I don't know. Who knows? But yes, I did. Thanks, Bex. So, yeah. So, yeah, if you've got a question, please do. But I've got to use up one of my 2 questions. So I'm going to use up one of my 2 now. Let's see how we get on. So question number 1. Do we offer dermal fillers or anti-wrinkle injections? Short answer or long answer? Of course, I'm going to do the long answer. Of course, I'm going to do the short answer, am I? Well, short answer is no, we don't. And we've been up and down and back and forwards, and some of the surgeons, actually probably all of the surgeons, apart from me, do it. Loads of people do it. And when I talk to colleagues who've well, not even got clinic, just other colleagues who are plastic surgeons, they all like, oh, you got to do fillers and sorry about that noise. I'm trying to close something that's not letting me. Fillers and all these anti-wrinkle injections or etc., such as Botox. And I can see why, because it's repeat business. A lot of the surgery I do is a one-off operation, which means I'm constantly looking for new patients, because as soon as I've operated on someone, that's it. Whereas if you have a non-surgical practice, you can have quite a small group of patients, but they'll keep coming back to you, and you can have quite a good business based on a much smaller number of patients than if you have a surgical practice, where you tend, particularly my surgical practice, which is breast and body contouring, so I don't do faces. So I haven't even got that thing where, people say when people are younger, they're having their breast done, and the tummy tucks a bit later on, and then the facelifts and the blepharoplasties a bit later on, so you can sort of treat people throughout their lives. But I don't do facial aesthetic surgery, so I haven't even got that. So there is definitely an attraction in having a relationship with the patient. Steady on, like a community. I'm trying to build a community, and definitely by doing non-surgical treatments, it does build on that community. And I love the concept of having a community around my clinic and having people coming back and and feeling part of the family. I really do love that, and I have been looking for a way of enhancing that. And you might think that doing this sort of thing would do that, but the problem with anything is it's not as easy as it sounds, because you have to get the patients, and that requires work, that requires producing content, producing information, talking about it, getting information out there. And because it isn't really my thing, and I've tried to get excited about it, I'm sorry, but I can't get excited about it. So I haven't, gone down that route of producing a lot of content for my website, etc. Also, I think if you get, well, it's not the case, but I believe that if you do something, you should be able to get people out of trouble. You should be able to sort of fix it, if you like. And because it's not my specialty, because it's not my niche, obviously fillers and Botox is mainly facial. I just feel like it's not really my area. It's not really my thing. And some people do a lot of it. Some people specialize it. Some people just do non-surgical stuff. And I feel like saying, look, let's leave it to them. Leave it to the experts. Leave it to the people who are doing it all the time, who love it. I should probably watch what I say, because maybe in a few years' time I'll be doing Botox and fillers and everyone will be going, remember that one? But anyway, it's facts. I'm spitting facts here. So, you can't argue with the facts. My view might change. I reserve the right to change my view, but at this present point in time, it is not something that I do, or it's just not my thing. And as I say, the other doctors do it, but we don't really promote it because feel that we should be doing things that I do. Rightly or wrongly, maybe wrongly. From a business point of view, definitely wrongly from what everyone says. But I guess it's sort of like my practice, my medical practice first, and a business second, I guess. But anyway, that's where we are at the moment. So we're not, as I say, we have been up and down and done and not done. And maybe if I get someone in with me, like a medical director or some other doctor, as a partner or something, and then maybe we might do it. But as it stands, it's a no from me. Lisa, what have you got? Lisa's got a question. Thank God for that. I've got 3 questions. Lorena, what are you playing at? Why have I only got 2 questions? Riddle me that. Riddle me that. I've got 2 questions. Anyway. I'm a professional, and you watch. I'll do my best. So, what's Lisa got? I have a question, a little off topic. We're all right with that. Do you give any creams advice to help scars from any breast surgery? How's that off topic, Lisa? That's bang on topic. Breast surgery. I mean, can't get more on topic than breast surgery. Absolutely, in the right place. That's a very good question. Well, scars are scars. Does it look naff if I have tea? I'm sorry if that looks naff. I feel bad doing it. Anyway, I'm not going to do that again. I'm going to leave that tea there because I think that I'll answer my own question. That does look naff. So, yeah, sorry, yeah, it's all right. It's all right, Amy. Don't worry. So, to be fair, Lisa, scars from breast surgery are the same as scars from anything. So this actually does apply to any scars in terms of managing scars and creams. So when you look at it, it's a huge market because people want to get rid of scars, and there's a big market in scar removal creams, scar reduction creams, etc., etc. But when you actually look at the facts of it and you look at the science behind it, there's very little evidence from a scientific point of view to say that one cream's better than the other. If they got someone with a scar and they put some cream on one half of it and they didn't put some cream on the other half of it, then maybe we can talk, but it's pretty patchy, the evidence. Having said that, I did go to a talk last year where they presented some stuff which was very interesting. I was chatting to the chap who's developed it, and he's a plastic surgeon. The other, last couple of weeks ago when I was at a meeting in London, and I was saying, and he's saying, why don't you use my stuff? And I'm like, well, basically, like anyone, you have to be nagged, to be fair. And I said, you need to speak to Vicky. You need to get your people to come and speak to Vicky. And he's like, well, we're trying to get it into the big supermarkets like Boots. I know Boots isn't a supermarket, but, trying to get into big outlets before they're dealing with individual surgeons. So that was interesting, that stuff. But I'm going off topic now, Lisa. So in general terms, in terms of creams, and the evidence as it stands, it's not great for normal scars, and most scars are normal scars. And what happens in a normal scar, at a week it looks good, 6 weeks it looks really red and firm, and then it starts to fade and become less red. And what happens is your body says, oh my God, I've been hurt, I've got to heal myself, throws in all this collagen, which is like a healing tissue, into the wound all over the place. And that makes it all higgledy-piggledy, makes it feel very firm, sort of rope-like, very firm, very red, raised. And then over time, a remodeling process occurs where the collagen starts to align and it starts to look a bit more like normal skin, and it goes skin-coloured and softer. And that happens to all scars, whatever you do. So that's a normal scar maturation. I do think that massage and moisturizing is the mainstay of scar management, and that's what we tell people to do most of the time. Now, I think there are things you can do that's good for your skin, and that means drink plenty, keep well hydrated, and avoid the sun. The sun's particularly bad for the skin, and the sun's particularly bad for scars, particularly when they're red and obvious, which is the first 3 to 6 months. If you get a tan on a scar while it's red, you'll keep the tan and you end up with a brown scar. But that's just general sort of skin things. In terms of specifically the scar and creams, moisturize and massage, and there's not really any great evidence to say that one thing is better than another thing. Nivea, E45, aloe vera, bio oil, aqueous cream, you name it. Some people say, vitamin E cream is great and aloe vera is great and things like that, and that's great. I'm like, if you've got an moisturizer that you like, then go for it. For me, actually, it's more the massage. it's more the massage than the actual cream that you're using. So massaging the scar, and as I say, this goes for any scars, whether it's your breast scar or any scar. You fell over and you hurt your leg. Moisturizer and massage will help it to soften and settle. Now, the scar reduction creams that they market are usually silicone creams. Silicone, which can come as a cream, or it's actually a gel, or a sheet, a silicone sheet. And they market them as scar reduction gel or whatever. But really, for me, the evidence is really for lumpy, red, lumpy, raised hypertrophic scars, which are abnormal scars. Hypertrophic scars are red, florid, lumpy, raised up scars. Now, a lot of scars look a bit red and a bit raised to start with, but they're not hypertrophic scars. It's normal for that to happen in the first couple of months. So for me, the silicone is really beneficial for a hypertrophic scar, which is an abnormal scar. I don't think you're going to do any harm by using it for a non-hypertrophic scar. I certainly don't think they do any harm to use it, but it is expensive. And if you are using the silicone, you can't really massage. You can't really do both, because if you put the gel on or the sheet on and you try and massage, you just move the sheet or rub the gel off. So you do one or the other. So for me, and even for a hypertrophic scar, moisturizer massage is good. So most of the scar reduction creams that you'll see in the shops are really, in my view, beneficial, particularly for a hypertrophic scar, which is an abnormal scar, which most people don't have. Most people have a normal scar. It might be a bit red and a bit raised, but that doesn't mean it's hypertrophic. So most scars, I would say, moisturize, massage. You have to let the wound heal. And again, you need to be guided by your surgeon as to when you start the massage. Personally, I usually do about 6 weeks for pretty much any operation, just because I want it to admit together pretty firmly. That's not, I don't think there's any evidence for that. I just, in my mind, want the wound to be pretty well healed before you start massaging it. So I normally start about 6 weeks, moisturize, massage. Obviously, with the breast, it's difficult to get to. So maybe morning and night, you can't do that very often. But if you've got a scar on your hand, 2, 3, 4, 5 times a day, if you moisturize, massage, and actually give it, that's why I have to wait for 6 weeks once it's, pretty soft. But once it's there, it's not soft, pretty well healed, not tender anymore. As long as it's pretty well healed and not tender anymore, give it a bit of welly, make the scar blanch, make it go white. Give it a bit of pressure when you're actually massaging it, circular motions. Well, I don't think there, but give it a good bit of a go. But yeah, nice question, Lisa. Thank you. Got a question on Instagram. Thanks. The Me Now. Hey, how often do implants need to be replaced? That's a big one. That's a big one, the Me Now. I wish I'd thought of that, because I've got to be honest with you, the Me Now. 10 minutes ago, I was desperately thinking of what I could make up a question and put it on myself, and I couldn't think of anything. But that, if I had, that would have been, I'd have been proud of thinking of that question myself. But thank you for that. A lot of people say they've got to be changed every 10 years. I really don't know where that's come from. I don't know where that's come from. We're in medical school or in plastic surgery school. They don't, that's not coming anywhere from plastic surgery school. So they don't have to be changed every 10 years. The implants themselves are often guaranteed for life. Most of them are guaranteed for life. Now, that just means the implant's guaranteed for life, not the surgery. So you still have to pay the surgery. But what that means is the implants are built to last forever. They're not, they're not supposed to be changed. Having said that, they probably will need to be changed. If you're having implants, you have to acknowledge that they will probably need to be changed at some point in your life. Now, around 5 or 10 years, they can start to go hard. And that's probably the most common reason for needing the implants to be changed. They go hard. And a lot of people say my implant's gone hard. Actually, your implants haven't gone hard. What's happened is you've got scar tissue forming around the implant. It's called a capsule. Everybody with a breast implant in has got a capsule. 100% of people has got a capsule. Your body will wall that implant off with scar tissue. That's a normal thing that your body does anytime a foreign body goes in there. So if you get shot, if you've got a bit of shrapnel in your leg, your body will wall that off in scar tissue. Now, the problem with an implant is that over the years, the capsule, the scar tissue contracts. Now, if you've got a bit of shrapnel in your leg, if it's a bit of metal, nothing happens because it's a bit of metal. But an implant is squidgy. So as the capsule contracts over the squidgy implant, it makes it into a ball, which is the lowest surface area to volume ratio, or is it the highest? Anyway, the surface tension thing, like a bubble, some kind of physics thing. Anyway, it makes it into a ball. So as a capsule contracts, it wants the shortest distance. So it does anyway. It just makes it into a ball. So it doesn't matter what implant you got. You could have a low profile, you could have a teardrop, you could have any sort of implant. It turns into a ball and it ends up looking like a high profile implant, basically, because it all gets compressed and it ends up sticking up and looking quite full. So it might look quite soft and natural. As the capsule contracts, it looks like a high or an extra high profile round implant, like they look quite full and quite high. And as that then continues, that contracture, that scar tissue, it gets painful. So that's the natural history of a capsular contracture. First of all, it looks. First of all, you feel it. Actually, the first stage is you feels a bit hard. Before you say, I can't feel the implants at all. Then it feels a bit hard, and then it looks a bit odd as you get this sort of fullness, and you think, oh god, they don't look very good anymore. And then it gets uncomfortable. At any stage along that route, you might want to have it changed. You don't have to have them changed. So as I say, it's not like they have to be changed at 10 years. They don't. You might want to have them changed. And if you have them changed, that's fine. We take all that scar tissue out and put a new implant in again. It's called a capsulectomy and the replacement of ear implants. The problem is that's quite a traumatic operation, creates quite a lot of scarring. And so another capsule comes quicker. So I normally advise people to leave it as long as you can before having a capsulectomy and change of implants, but that would be the requirement, have them changed. And when you do change them, when you take them out, you get this really hard ball. You take this hard ball out, you open it up, you open the capsule, out comes the implants. The implant's happy as Larry. The implant's just a normal implant. All of a sudden the implant, just goes to its normal shape. So the problem is not the implant, it's the body's reaction to the implant. It's the scar tissue that's caused it going hard. So strictly speaking, when you say the implant's gone hard, it's not actually the implant that's gone hard. It's your body's scar tissue that's formed around the implant that's made it feel hard. The implant is actually fine. So that's the most common reason to have them replaced. There's other reasons to have them replaced. Rupture, which is pretty rare, to be honest. And sometimes you get what's called a silent rupture. You don't even know about it. And it's held within the capsule, which... personally, I don't routinely scan people. Some people routinely scan people at 10 years or something like that, looking for these sorts of problems. I don't routinely scan people. I go on the clinical grounds because the scans are not 100%, and sometimes the scan can throw up something, and you think, oh crikey, what should I do? And you might have to go through the risks of having surgery with not being sure if there's actually anything wrong with your implant at all. And if it's an intracapsular rupture, it's held within that capsule. But so I don't personally recommend scanning people routinely. The main reason, I guess, for scanning would be rupture, because capsular contracture is a clinical diagnosis. You don't really scan people for capsular contracture. You can feel and see that. And the other reason for having implants replaced, I guess, is ALCL, but that's extremely rare. 1 in 6,000 to 1 in 60,000 people. It's very rare, but that's a lump or a swelling sometime after having implants in. I mean, I suppose the other things are, size, not happy with the size, and breasts drooping and wanting a different shape and stuff like that. But that's more of a cosmetic issue rather than them needing to be replaced. So they don't. So if this gets chopped as a clip on YouTube, and the clip says, how often do implants need to be replaced, I'm probably going to get loads of comments saying, you haven't answered the question, you haven't answered the question, you haven't answered the question. Like, how long does dissolvable sutures, that grief I got on my how long does dissolvable sutures question. Look at that on YouTube. I've answered a question. Someone said, how long are dissolvable sutures? The thing people on YouTube don't realize is I haven't made the question. Someone else has asked the question, asked me how long a dissolvable sutures last. And I'm like, it varies. Varies where they are, what sort of suture they've used, how big the suture is. There's all sorts of different types of dissolvable sutures. And then I've got all these comments saying, yeah, I want to ask the question. Well, what do you want to say? Can't answer the question. There's not an answer to it. I haven't asked the question. I think they think I've asked the question and put it on YouTube myself. But I haven't done that. Anyway, I'm a professional and I'm just going to rise above it. It doesn't faze me. Look at me. Like the ocean. Yeah. We've got stuff going on. Lorena said, sorry, you're okay. Olivia, long time no see. Olivia on Facebook, good to see you. Berg, I hope mine don't need changing after 5 years, already 2 years old. Hashtag, oh, look at that, Olivia, legend. No, not 5 years, Olivia. 5 years would be pretty early. I mean, 5 to 10 years, they can start to go. Having said that, people have 10, 15, 20 years. So I would say don't even worry about it. Don't even look for problems. If you have a problem, then obviously seek help. But if you don't have a problem, That's fine. Carry on. A bit of positivity. That's what we need. Karen's here. Hi, Karen. Winky Sparkle. Winky Sparkle, you're not another one like the one last week, are you? Anyway, we'll go with it. Let's have a look at the question. How long should one wait after a liposuction surgery scar before getting the cannula entry scar revised, fixed? Short answer, Winky Sparkle, which obviously I'm going to follow up with a long answer. But short answer, 1 year. Long answer, scar doesn't start to settle till about 3 months. So at least 3 months, probably 3 to 6 months, really. Essentially, the longer you wait, the better, because scars really do improve significantly. So 3 to 6 months would be the minimum. But really, for scar revision, especially something like a liposuction, that's going to be like a dented in scar, isn't it? Dented in scars, Winky Sparkle, are difficult to treat, because when we do the surgery, we create scars. So if you've got a dented scar, you say, look, I hate this scar. Can you sort it out? What do you want me to do? What am I going to do? Cut out the scar, stitch it up. I've given you another scar, haven't I? Why is mine not going to go dented in? Now, having said that, don't want to underestimate the old plastic surgery skills. There are things we can do to try and bolster up the scar, but nevertheless, scar revision is tricky. And if you've got a dented in scar, is it dented in, actually? You haven't said. I'm assuming it's dented in. I don't know why I've assumed that. I'm assuming it's dented in. So if it's lumpy, then you're probably looking at things like silicone and massage and steroid injections and stuff like that. So it's either lumpy or dented in, I guess. Those are the two options. But let's go with the dented in. So the problem with the dented in thing is that, what am I going to do? So you want to wait as long as possible. And really a year is when, if it's still dented in at a year, you'd be thinking, okay, fair enough. That might not be getting any better. But if you can live with it, obviously if it's terrible and it's like, hopefully, we try and put liposuction scars in out of the way places. So hopefully it's in a bit of an out of the way place and not a big problem for you. But, you never know. If it is a big problem, then you might consider doing it sooner. But it's not as easy as you might think, Winky. It is not as easy. Kelsey's here. Good to see you, Kelsey. The Me Now. Thank you for explaining another question. Oh my God, the Me Now's got another question. Well done, the Me Now. If I didn't know who you were, which I don't, I would think you were a ringer. I mean, if I was an outsider, because this is brilliant. Thank you. Amy, take a leaf out of the Me Now, will you? Because she's asking some good questions here. Well, I haven't seen what the second one is, but the first one was a good one. Is it possible to have implants with just an incision around the nipple? I have inverse psoriasis under my breasts. I asked about incisions and psoriasis. So yes, it is another good one. Around the nipple, yes, the Me Now, it is another good question there. I don't think I could. I don't think I can. Anyway, so basically, the Me Now, there are 3, I would say, incisions for putting an implant in. One is a U-shaped incision at the bottom of the areola, which is the one I think you're talking about when you say an incision around the nipple. So it's a U around the bottom of the areola, and that's called an infraareolar incision. One is at the fold of where your bra sits, which is an inframammary incision, and one is in the armpit, which is called transaxillary. So those are the three options. People talk about the umbilical one, transumbilical breast augmentation tuber, but that's really for saline implants, so they put an empty plastic bag in and blow it up. So I think, that's not really anything that I've seen. So let's just stick with those 3: infraareolar, inframammary, transaxillary. Now, anytime there's lots of ways of doing something, that means there's no one good way of doing it. So there's pros and cons of all of them. The Americans seem to use the infraareolar more than we do. We don't tend to use it much. Now, and there's pros and cons. So first of all, you've got to be careful of anyone trying to tell you one's better than the other. Now, full disclosure, I pretty much always use inframammary, which is in the fold down here. But I completely understand why people might not want that, because it's on the breast, it's on normal skin. You can see that potentially, I lie down and I can see that. And the infraareolar one that you're talking about, when it heals beautifully. It's pretty much invisible. I use it a lot for men for gynecomastia correction, and that when it heals, it's really hard to see. The couple of issues I've got with it personally, and the reasons that I don't use it, is number one, you are potentially going to damage some nerves around the nipple, so there's an increased risk of alteration in nipple sensation with that incision. Whereas with the inframammary, you're just sort of pushing all the nerves. So whilst you can get funny feelings to start off with, it usually comes back to life. So there's more of a risk of damaging some of the nerves to the nipple. And the other thing is, if perish the thought you had a bad scar, it's really bad because it's on your nipple and it's really, so it's, as I say, it's extremely rare to get a bad scar there, but if you did, it's a bit of a disaster. Whereas with the inframammary or the transaxillary, those scars are a bit more easy to hide because they're sort of hidden underneath your breast or in your armpit. So those are the two reasons that I'm not a great big, I just don't do it. Well, I'll say I don't do it. If I was doing something like a difficult tuberous breast or something like that, and I had to make a scar around the areola and didn't have another scar, you can put the implant in that way. When you do it that way, you have to cut through the breast tissue to get the implant underneath the breast tissue. So you cut through more breast tissue when you're doing it that way. The transaxillary and the inframammary, you're just sort of going straight underneath the breast tissue, so you're not actually cutting through breast tissue. So yeah, it's not something that I do, but in answer to your question, yes, it is possible to have that incision there. The worry is that if you did get a bad scar, it's on the front and obvious. And so, plus, for me, the inframammary, I like it because you can get really good exposure and really good vision of the place where you want to put the implant, which is why I prefer it to the transaxillary, because I find it's quite hard to see, particularly here in the cleavage area, which is really important to get the cleavage area right, and there's a lot of big blood vessels there. So I find that the inframammary is the best balance between the three, and so that's why I tend to favor that one. Kelsey, hey, good to see you. Okay, 1 year, thank you. Yeah, no, it's raised. Oh, if it's raised, one Winky Sparkle, you might want to look at doing something. So was that is the liposuction scar? Is that Winky Sparkle? Yeah. So if it's raised, Winky Sparkle, I might actually, Amy will know, Amy, if it's raised, then I might do something a bit sooner, Winky Sparkle. So if your liposuction scar is raised, then that suggests it might be a hypertrophic scar. So again, moisturized massage, like I was saying earlier. But a raised scar, you might think about it. A raised scar is difficult to treat surgically. So you'd be looking at non-surgical treatments such as steroid injection and silicone gel or sheets, depending on where it is. Pressure, if that's appropriate for where it is. So then you're in the realms of hypertrophic scars, Winky Sparkle. So that you would probably look at about 3 months. You might be starting to do something sooner because it wouldn't be scar revision. You wouldn't be cutting that scar out. Alex, long time no see. God, this feels like a long time. Probably isn't, is it? A couple of weeks. But anyway, how you doing? Speaking of a long time, Olivia says 3 years in November. Wow, 3 years. Well, that's brilliant. Well done. So hopefully... yeah, so Winky Sparkle might be worth getting that looked at sooner, actually, rather than a year, because it could be a hypertrophic scar. And steroids, pressure, silicone, go for that. Well, I've got to be honest, everyone. Well done, you, honestly. Pat on your back, because you've asked some good questions there. I'm on my second question now, the second preordained question. Do we remove osteomas? So an osteoma is a bony lump, and you can get an osteoma in any bone, a bit of bone that's sticking out. The common places that I've ever seen them as a plastic surgeon, and I treat them with a plastic surgeon, is on the forehead. We seem to get quite a few on the forehead, and sometimes when someone comes with a lump on the forehead, you always think, actually, is it bone? Because it could be a cyst, or it could be a lipoma, or it could be some soft lump. But occasionally it's an osteoma, which is basically a little bump on the skull itself, on the cranium. So that's the common places where I've seen them and treated them. I mean, you can get an osteoma anywhere, on your leg or on your arm, anywhere else. But I guess it would probably be an orthopedic surgeon. I guess it is on your legs or arms and things, rather than us. But we tend to do the ones on the forehead. And the reason this question has gone on is because a patient inquired in the week And I basically said no, we wouldn't do it. And the only reason I said no, we wouldn't do it is because we can't get the kit. Because I've got a minor operating room in my clinic, and every bit of kit I've got in the minor operating room is disposable. And when you do an osteoma, you need a hammer and chisel, basically, because it's a bit of the bone. Trust me, you need a hammer and chisel, because I tried to do it without a hammer and chisel, and it's an absolute nightmare. So, and it's relatively simple with a hammer and chisel. Believe it or not, you do it under local anaesthetic. It is a bit like your head's going a bit like that as we're going, dit, 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 you know, to get it off with the hammer and chisel. But so it's a doable thing under a local anaesthetic. The reason we've got an issue with it at the clinic is because we can't get I don't even know if they make. I don't think they make disposable hammer and chisels, basically. So we were going to have to buy a hammer and chisel, which would be like 150 quid or something for a sort of sterile hammer and chisel, and then just throw it away, or bring it home, put it in the garage if you ever need anyway. Or basically throw it away. I suppose the first one you bring home, but after that you wouldn't want it in the garage, would you? So the bottom line is just not worth it, because we haven't got sterilizing facilities. But if you went to your local private hospital, they would have sterilizing facilities, and they'd have a hammer and chisel. And if I did it at the local hospital, it would cost more, basically. So that's why it's easier for me to just say no. Maybe you're better off going to the local hospital and your local hospital. But maybe I should have offered. Thinking that now I think about it, maybe I should have offered to do it. But anyway, Amy, if you're still on there, talk to me about that tomorrow. Maybe we should have offered to do it at the hospital. But anyway, at the clinic we can't do it because we can't get a hammer. And goodness knows, Vicky has moved heaven and earth to try and get a hammer and chisel and disposable, or to get them to take it away and sterilize it and then bring it back. And the logistics of it was it broke her, basically. So we've decided no, we're not going to do the osteomas. They're quite nice when you got the right equipment. They're quite nice to do. When you haven't got the right equipment, they're a living nightmare. I've been through the living nightmare trying to get it off with a flipping scalpel and things. And when you got the right equipment, it can be quite beautiful, just chipping it off. But like anything in life, it's bad workman, not bad workman, but workman and his tools. Because I think a bad workman blames his tools, but I think when you haven't got the right tools, it does make things a lot easier. But for now, we haven't got the tools for osteomas. Certainly out of the clinic, we haven't got the tools. So I would go to your local private hospital. But if you are watching and you have got an osteoma, I have just had a thought that we could probably offer to do it at the hospital, although it would cost more. Doing things at the hospital does cost more than doing it at the clinic. But at least we could, give you a quote so you can make a decision on whether that's worth it or not. It's just a bit galling, because if we had a hammer and chisel, we could. I suppose you could ask yourself how much more. If it's more than 150 quid more, why don't we just buy a hammer and chisel every time we do one? Thinking aloud here now. Anyway, yeah. But we have been through a lot with the osteomas, and we have decided not to do them because it was too difficult to get that. Well, I thought that was pretty good for 2 questions. If anyone has got a question, obviously I'm a busy man, obviously, but a bit of time. Cold tea, stone cold. Yeah, obviously a busy man, but okay. So on that note, thank you. Not only the 2 people who have asked me the osteoma and the dermal fillers question, but also wrinkly pierce, winky sparkle, the me now, too many to name. Lisa. Actually, that's it, isn't it? Yeah. Okay. So those 3. Anyway, thank you to those 3 for asking your questions. And please God, I'll have some more questions next week. Otherwise, I'll have to frantically think of something myself, and nobody wants that. And I will be here, assuming everything's all right next week. I don't know what's happening next week. Anything? Yeah, let's assume so. So I will catch up with you then. thank you for tuning in, and I will wish you a good evening and a good night. Good night.